Good morning, everyone. Welcome to session D5. This session's on opioids, and generally we do a little bit of an introduction, but I kind of feel because opioids and pain have come up in just about every session that we've had so far, I don't think I'll spend much time setting the stage for our speakers today and instead let you listen to what they have to say. So I'm Janice Mann. I'm in Knowledge Mobilization at CADTH, and I'm the chair of the CADTH Opioid Working Group. And as I said, today's presentations will all focus on some aspect of opioids and the opioid crisis. A reminder that there is another session on opioids today, right after lunch at 1:15, and that's a panel discussion bringing different perspectives, talking about the treatment of opioid use disorders. So just a reminder of that as well. And I wanted to welcome those that are online. This is a webinar as well as an in-person presentation, so welcome to all those who may be listening from wherever they are. Just a reminder before we get underway, we will have questions at the end. Each speaker will speak for about 15 minutes, and then that should leave us at least 15 minutes at the end for some questions. Those in the audience, just raise your hand. We might bring you up to a mic so that people can hear you. But if you're online, you can send your questions to events@cadth.ca. So that's events@cadth.ca. So, not to take away time from our excellent speakers today, I'm going to introduce our first speaker, Justin Yu. And Justin is the Senior Manager of Global Health Economics and Outcomes Research at Allergan. And Justin is going to speak to us today about migraine treatment patterns and opioid use among chronic and episodic migraine patients identified by a clinician-administered semi-structured diagnostic interview. So, welcome, Justin.
Good morning. Can everyone hear me okay? All right, so my name is Justin Yu, and today it is my pleasure to be presenting on the topic of migraine treatment patterns and opioid use in chronic and episodic migraine patients identified by a clinician-administered semi-structured diagnostic interview. Throughout this presentation, I'll share a little bit more about the diagnostic interview. It's the approach that we took in this study to be certain of whether or not a patient had chronic migraine, given that especially in the US, we see a lot of underdiagnosis of the condition. And the data that I'll be presenting today will be from a US medical group, but I believe that it's also very applicable to the Canadian population, given that there is a shared interest in both the US and Canada about the increasing use of opioids in the general population, and especially those that have chronic pain. In the US, for example, there is an opioid epidemic. Data from 2016 suggests that 2/3 of drug-related overdose deaths involved an opioid. And in relation to Canadian data, we also see something similar. For example, based on data from Ontario, from 2003 to 2016, there was a greater than 130% increase in the number of opioid-related deaths. And so the use of opioids is a concern, especially in chronic pain. Migraine is a chronic disease in which pain is a defining feature. So I believe that the information I'll be sharing today is both timely and relevant. And I hope that it opens up discussion for additional thoughts in terms of how we can better manage patients that have migraine. I am an employee of Allergan, and my other collaborators in this project are employees of Healthcare Partners, which is the medical group in the United States that we work with on this project, as well as clinical experts from academic institutions around the US that we work with. Migraine is a leading cause of disability in the US and affects approximately 12% of individuals in the US. In Canada, it's approximately 10% from recent surveys that I've looked at, but globally we've seen this number range anywhere from 10 to 14%, so it could vary from region to region. Individuals that have migraine report reduced productivity, missed days from work and school, and also decreased health-related quality of life. Additionally, in relation to migraine, we typically think about it in terms of chronic and episodic. Chronic can be largely characterized as having 15 or more headache days per month, and episodic migraine can be thought of as having less than 15 headache days per month. In comparison for chronic compared to episodic, chronic migraine patients tend to have more disability. They're less able to get out of the house, do chores, do errands, see their family, do social activities. Chronic migraine patients also tend to visit the doctor more, go to the emergency room more, which translates to higher costs. And at the same time, we have greater medication use, both acute and preventive, and also the use of opioids, which we have observed in multiple claims-based studies and also survey-based studies. And lastly, with increased headache frequency comes greater absenteeism and presenteeism, and also greater functional and emotional impact for patients. And so for migraine, people that have this disease can be treated with both acute and preventive treatments. Acute treatments are used if they have a migraine that occurs and you want to abort it or to reduce the symptoms of it, and preventive treatment is used to prevent the occurrence of migraine or migraine headaches. In the past, we have seen that opioids have been used for treatment of migraine. In a 2004 study based on Canadian patients, for example, although it is a little bit outdated perhaps, but I think we still see a lot of opioid use, 60% of Canadians that visited 5 different emergency departments received a narcotic for treatment of their migraine headaches. So I think that speaks a lot to the use of opioids in the migraine population. From what I'll be showing today, you'll see that it also appears to be the case too in the US, where a lot of chronic and episodic migraine patients are using opioids. Although opioids can be used for migraine, they are not recommended. Both US and Canadian experts both agree that they should not be used as the first-line option. If anything, they should be used as the backup plan, which should be considered first are non-opioid pharmacotherapy or non-pharmacologic therapy in order to optimize care for these patients. The use of opioids are not recommended in addition to that because regular use can result in medication overuse, dependence, and also opioid hyperalgesia. The objective of this study was thus to describe migraine treatment patterns and opioid use in chronic and episodic migraine patients using health claims data. The patients from this study were enrolled from a large medical group in the United States known as Healthcare Partners, and the patients that we enrolled into the study were at least 18 years old, so they were adults, and they had to have had at least one claim with a migraine diagnosis in the 12 months before they were screened into the study. Among the patients that were ultimately enrolled into the study, we first administered them the Identify Chronic Migraine Screener, which is a validated screener for identifying chronic migraine that was developed a few years ago. For the purposes of this study, we wanted to gain additional real-world evidence on its validity, and so that is assessed in a separate analysis. For a convenient sample of patients that were enrolled into the study, we administered to them the semi-structured diagnostic interview, which is the gold standard diagnostic that we used. It's developed by leading headache experts in the US in order to truly know whether or not a patient has chronic migraine, given the difficulties in diagnosing the condition. And lastly, we assessed acute treatment patterns, preventive treatment patterns, and opioid use in both the chronic and episodic migraine patients in the study. I'll spend a little bit more time now and talk about the semi-structured diagnostic interview. This is a very rigorous interview that was developed by headache experts in the US in order to truly understand whether or not a patient has chronic migraine. In the US, population-based studies have shown that 75 to 80% of chronic migraine patients don't receive an accurate diagnosis. And so for the purposes of this study, we wanted to be as certain as possible that we knew whether or not a patient had chronic or episodic migraine. The semi-structured diagnostic interview is 20 to 25 minutes in length on average, and it consists of 31 questions that a physician asks a patient about the headache symptoms, frequency, medication use, in order to get a really good understanding of whether or not they have chronic migraine. And it's very rigorous in nature in the sense that there's a computer-based diagnosis based on objective information that's recorded during the interview with the patient, and also a physician diagnosis, which is based on that objective information and also their opinion of whether or not a patient fits the criteria for chronic migraine. And to be absolutely sure, we checked both those diagnoses from the computer and the physician. There was very little disagreement on average, but in the event that there was, then a headache specialist would make the final determination as to whether or not a patient had chronic migraine. And that's how we categorize our patients as chronic or episodic for this analysis. For the assessments, we looked at patient demographics and also clinical characteristics. We also looked at acute and preventive medications that can be used for migraine. For the purposes of this study, we focused on those that had level A or B evidence from the US Clinical Practice Guidelines, and also some based on clinical expert opinion. Upon review of the Canadian guidelines for prevention, I believe that they're quite similar to the US guidelines because the same medications, for example, that are designated as having high quality evidence are similar between both guidelines. For example, topiramate, amitriptyline, metoprolol, propranolol. So I think we'll see a lot of similarities here. And lastly, we looked at opioid claims in order to get a better understanding of how much opioids chronic and episodic migraine patients are using within this healthcare setting. And Each of the variables that we assessed were done using descriptive analyses because we wanted to describe the chronic and episodic migraine patients as they appear in terms of their characteristics within the medical group that we studied them. In total, we enrolled 192 patients, and those were the patients that were administered the semi-structured diagnostic interview in order to determine whether or not they had chronic or episodic migraine. We found that about 2/3 of patients in this study had chronic migraine, and about 1/3 had episodic migraine. When you look at that, the first thing that comes to mind is chronic migraine prevalence from studies we've seen is usually around 10% out of all migraine patients. And my hypothesis for why we're seeing a much higher percentage of chronic migraine patients in the sample is that we enrolled patients that had a migraine diagnosis on a medical claim within the past year. So these are likely the patients that are seeking care for migraine, perhaps those that are most severe. And therefore, it wouldn't be as surprising perhaps that those would be more likely to be high-frequency episodic migraine or perhaps chronic migraine. But nonetheless, I believe that it does represent the typical patient that healthcare partners, the group we work with, is seeing on a general basis, and perhaps in other healthcare settings as well. In terms of their comorbidity profile, when looking at the Dale-Charlson Comorbidity Index score, the score was slightly higher for the chronic compared to the episodic migraine cohort. However, overall, the comorbidity score was relatively low, which does make sense when you look at their age. It's roughly high 40s, so these patients are relatively younger. You wouldn't expect as many comorbidities. When looking at the percentage of females, it is relatively high in both cohorts, which is consistent with migraine as a condition. And also we see that it's higher for chronic compared to episodic migraine, which is also supported by the literature. We focused on 3 comorbidities in particular: comorbid pain other than migraine, depression, and also anxiety, based on the prevalence that we have observed in past studies. And we can see here, for example, that the prevalence of pain other than migraine is higher in the chronic compared to the episodic group. Additionally, when looking at anxiety, it's roughly the same for the chronic and episodic cohorts. My hypothesis is that usually we see more anxiety in chronic migraine patients, but it could be that the patients we enrolled into the study were chronic migraine or high-frequency episodic migraine, where they're very similar together in relation to that, and so therefore we see a more similar prevalence of anxiety. When we look at depression, however, we see that the prevalence is almost twice as much in the chronic compared to the episodic cohort, and this is consistent with what has been observed in other studies. In relation to treatment patterns, in this study we found that 93% of those with chronic migraine and about 83% of those with episodic migraine had at least one claim in the past year for either an acute or preventive treatment. So we know that the majority of these patients are receiving some type of treatment for their migraines. In relation to the number of patients that had minimum pharmacologic care, which we define for chronic migraine as having at least one acute and preventive treatment, we see that 2/3 of those with chronic migraine and 56% of those with episodic migraine had at least one claim for both an acute and preventive treatment. The key point to take away here is that it is possible, perhaps, that some migraine patients may be using over-the-counter medications or medications with a lower level of evidence, but whenever you have a chronic migraine patient, it's important to make sure that they have access to both an acute and a preventive medication because they will need both. And lastly, when looking at the number or the percentage of patients that had claims for at least 2 unique preventive classes for prevention of migraine, you see that it's 46% of chronic migraine patients and about 22% of episodic migraine patients. This is consistent with what we've seen in the literature as well, because chronic migraine patients tend to cycle between preventive medications more, either due to lack of efficacy or tolerability. In relation to opioid treatment patterns, 54% of chronic migraine patients and 37% of episodic migraine patients had at least one opioid claim within the past 12 months prior to enrollment into the study. Furthermore, when looking at the average number of claims for an opioid in the past year for chronic and episodic patients, we see that chronic migraine patients had 4 claims on average in the past year, and episodic migraine patients had 2.8 opioid claims in the past year. That number numerically may not seem like a huge difference, but I would say that with every additional claim for an opioid, every additional day supply, and every additional pill, there is an increased risk that is posed to the patient either due to dependence or abuse, or perhaps unwanted adverse side effects. And so it's important to make sure that we're able to manage these migraine patients appropriately. And lastly, 33% of chronic migraine patients and 16% of episodic migraine patients had at least 3 opioid claims within the past year. And you can see here it's higher for the chronic compared to the episodic group, which is consistent with the results that I showed above. In terms of the limitations, as I spoke to before, the acute and preventive medications were based on those that had level A and B evidence from the U.S. clinical practice guidelines. There could be differences depending on different regions, but I believe that globally, a lot of these medications that have high quality evidence are accepted across different regions. Additionally, some medications can be used over the counter, which would not be recorded in the claims data. And so that is a possibility. If anything, we may be underestimating the use of acute and preventive treatments in this population. And lastly, the pharmacy claims that we were looking at were used to evaluate opioid use. Looking at medical claims is much more difficult to identify the different codes to bill for opioids, and so we may be underestimating the use of opioids within this population. And lastly, the analysis was limited to patients with the diagnosis of migraine in the past 12 months prior to screening for the study. And so these are likely the patients that have more severe migraine, more frequent headaches, that are actively seeking care. And so it's not a surprise that perhaps these are the more chronic patients or the high-frequency episodic migraine patients. But based on claims analyses that we've done, we see that even though migraine prevalence may be 10 to 12 to 14% based on population-based studies, when looking at claims data, which is similar to the study, usually migraine prevalence that I've seen is about 2%. So it's really the most severe migraine patients, in my opinion, that are going to see the doctor. And these are likely the patients that are representative of what we'll typically see in clinical practice, at least in this healthcare setting. In conclusion, approximately 2/3 of patients with chronic migraine receive prescriptions for both acute and preventive treatments, which we define as minimum pharmacologic treatment. Additionally, more than half of patients with chronic migraine and about 1/3 with episodic migraine received at least one claim for opioids within the past year. And given the prevalence of opioid use in migraine patients, both chronic and episodic, as we saw in the study, it suggests that improved management of treatment is needed to optimize care for these migraine patients. And I hope that with these results, we will continue to drive the discussion and raise awareness on the need to appropriately treat migraine patients, especially when it comes to using opioids. Thank you.
Thanks, Justin. I should have mentioned as well that we did change the order slightly from your program. So if you're wondering what we're doing here, we're just keeping you on your toes today. So you'll have to pay attention to who's talking to know which presentation is coming. And just a reminder as well that we'll do questions at the end. So if you have questions for Justin, just hold on to them and you'll have an opportunity at the end. Our next presentation actually has 3 people presenting. We have Heidi Liston, the Director of the Drug Utilization Program at the New Brunswick Department of Health, Stephanie Smith, our CADTH liaison officer for New Brunswick, and Pamela Jarrett, who is a geriatrician with Horizon Health Network in St. John, New Brunswick, and a medical officer of primary health care with the New Brunswick Department of Health. And that's only part of everyone's bio here, so if you want to learn more, please look at the program as well.
Well, thank you. You'll understand why we came as a team today when we're talking about sort of stakeholder engagement and collaboration. And what we're focusing on is the prescription side of the opioid crisis. And we're basically wanting to share what our experience has been to date and what has worked in terms of sort of preparing the landscape in terms of education and getting folks ready for that change, motivated to change in terms of behavior. And I'd like to start with saying we were one of the last provinces to actually have a prescription monitoring program, but we really were in a very great place to sort of look at what has happened in the U.S., what has been happening across the country. And so we came into this really with a vision that, look, this is not a punitive system. We want information to be there at the fingertips of clinicians at the point of decision making before pen hits the paper, and kind of not that pharmacists aren't a critical part of that, patient care and help in decision making, but we felt we often put a lot of responsibility on the pharmacist to kind of police, get back, and by the time that prescription's left the physician's office or another prescriber's office, it's a bit more challenging in order to rein that in. So our focus was on prevention, with primary care providers being our primary focus. We also wanted to look at new patients. It wasn't like trying to let's go find all the worst patients in the province on super high doses of opioids, and let's just focus on making changes to that group. Because if we didn't change behavior at the ground level, we're just the bucket just keeps getting filled. And so we wanted to make sure there was support for new patients, people who've never had an opioid being identified early on, and also looking for a mechanism to share information also in real time that's evidence-based, supporting guidelines. And what we heard early on was kind of a fear that, as soon as the PMP starts, we're going to have the overdoses are going to start happening. And you'll understand with what we've done in some of the collaborative educational and other types of endeavors is that the message has always been the PMP is not to find people and cut them off suddenly. So that's been something critical to some of the information we've been sharing. So I'm very pleased to say that we've stood up, in addition to having all of the monitored drugs viewable to clinicians in real time. This is our enhancement that we've been working on from a technological standpoint. So I should back up just 1 second too, because our learning around sort of making this a patient-focused endeavor is we didn't want our PMP over here and, our EHRs over here, and other information's over here. And so we took full advantage. Our PMP is integrated within the electronic health record. It's there not to just treat a patient's monitored drugs, it's about treating that whole patient. So when folks log in, they can pick the prescription monitoring program and come to this page. The other kind of groundbreaking, I'll call it, New Brunswick has done with this is that the EHR, the Provincial Electronic Health Record, has been largely a repository of information. That's been, all the labs from the province, all the prescription medications from community pharmacies are there, interactions with the healthcare system, and so on and so on. But nobody has looked at this as a tool for exchange of information, for provision of information to others. And so we've actually built an application where once logged in, a prescriber can go add additional information, sort of identifiers for a patient, whether they have an active substance use disorder, they're a terminal or palliative care patient, which would help qualify some of the information they might see around the prescription drugs that have been dispensed for them. There's also the ability to go in and select them as a prescriber, others that they work with, pharmacies where they want that patient to go or they've agreed to go as part of a formal treatment agreement that exists outside of the EHR. That's part of the clinician-patient agreement that is often used by both pharmacy actually and as well physicians when they're engaging in prescribing opioids. And it does not just include those restrictions. It may include, you're not going to share medication. I'm going to come and do all the UDSs on time when asked and those things. But what it will do is at the pharmacy, so it still uses that pharmacy system in a way that if a patient went outside that agreement, an alert would be fired at the pharmacy. But it doesn't stop there. The alert is generated in real time directly into the patient's electronic health record. So a prescriber who is working and regularly working in there would actually get notification, there's information here on a patient that I can go look at. So we're hopeful that will help spur additional access and use of the EHR in general. And there's still more to come. We have more alerts and other things that we're looking to do. So that said, everyone says, if you build it, they will come, and that's kind of doesn't really ring true in a technology world with physicians in an aging population and range of demographics in terms of physicians and where they are at a comfort level with technology. And I was talking with with Pam earlier, and she was saying, sometimes it kind of gets into the way of workflow, and that's precisely kind of how many prescribers and others kind of view having to go in and out of these kinds of systems. So we knew from the start we had a bit of a change management role to play here. And so before we even put any kind of work on paper or planning on paper, we actually went out and it's something that we think we do as government routinely, kind of go out, consult, but it's, I see it more as sort of like dipping the toe in the water. Oh, we got our information, we compiled it, we consulted, now we're going to move on. And unless you really bring people with you from the start and on through, it's really hard to get that buy-in, that motivation, that desire to change, which ultimately can lead to behavior change. So we identified who we wanted to work with, what are some of the, sort of tactics we were going to use, and I'll get into some of those details a little bit, but I want to make sure I give time for the others and tell just how good a job or where we need to sort of still do some additional work. But we really have formed some great alliances with all of the healthcare professions, whether they be their interest group, the licensing body, as well. CADTH has played a huge role in helping us roll out a lot of what I call setting the stage. And in an old life, I worked for pharmaceutical industry after leaving academia, and we don't use enough of the tools that they employ. Obviously, they've been quite effective at sort of skewing or influencing how physicians prescribe. But here we are on our end saying, and behavior management has been, or behavior science has been something long been used for a long time in pharmaceutical industry. So with that, we've to date, with all of the stakeholders at the table and everybody helping to engage what we want to do, we've had multiple face-to-face, live, educational sessions, so much so that over the last couple of years, we basically had a session a month. And it seems like a lot of work, but once you have it started, it kind of rolls out on its own. So I would encourage folks to consider the more you plan and the more you bring people along from the beginning, the easier it gets down the road. So that initial investment in both, time and energy actually pays dividends at the end. So I'm going to stop there and have Stephanie, who's our CADTH liaison and who we've worked closely with on a lot of the endeavors that we have done to date. Thank you.
Okay, thanks, Heidi. So as many of you would know, CADTH was involved in the 2017 Joint Statement of Action to address the opioid crisis. And specifically, CADTH pledged to deliver, and we've been delivering, evidence-based recommendations, advice, and decision support tools in two key areas, that being the areas of pain management, including both drug and non-drug interventions, as well as treatment of opioid use disorder. And so we all know that compiling evidence and documenting what we know and what we don't know is certainly very critical, and CADTH is excellent at doing that. On the other hand, there are times when compiling evidence and content at a national level and ensuring that it can reach people who could use it at local levels in a way that makes sense to them and works well with them can be more challenging. And but I'm happy to say that CADTH certainly has expertise as well as dedicated resources in that area as well through our knowledge mobilization and implementation support team. And I'm proud to say that I'm a part of that, being the New Brunswick liaison officer. So in this effort, knowing that this was happening in New Brunswick and knowing what we were doing with CADTH, there was certainly an excellent opportunity for us to collaborate and see how we can use CADTH evidence and our implementation support opportunities to support New Brunswick's initiatives in a way that makes sense to them. And I should give a little shout out here to Janice Mann because she leads our opioid work with CADTH. And through her and our efforts, we've developed a lot of tools and products. These are a quick example of the evidence bundles that we've developed and collated all of our content online. So it provides a quick, ready place for people to access our evidence and tools. These were actually referenced in the new opioid guidelines that came out last May as a quick resource for health providers in informing their treatment decisions. Going quickly here, other resources as well as an infographic we collaborated on with ISMP Canada supporting navigating opioids for chronic pain. And all of these resources that we've developed have been shared very widely in New Brunswick and were part of the delegate packages for all the education sessions that were delivered. And hearing this morning about the multimodal opportunities and ways to get information to people and how important that is, we've been supporting a lot of peripheral activity as well and getting information out through exhibits, for example, here at the New Brunswick's Opioid Symposium in December, newsletter articles in our health professional newsletters like the Nursing Association and Medical Society. And moving forward, we definitely like to continue with the collaboration, and our work certainly is driven by customer need and priorities. And with that in mind, we're presently supporting a pilot looking at the development of a slide library that could then be used to develop online learning modules, and recognizing that it's difficult to reach everyone in face-to-face opportunities. We're also going to be developing links to the CADTH content within the electronic health record and looking at other opportunities, other priorities like the benzodiazepines that might be built into the prescription monitoring program and where CADTH evidence could support that as well, and lots more outreach in the future. So I'm going to provide some time now for Pam to talk about this experience from the clinician perspective.
Thank you. Thank you very much, and I'm pleased to be able to be part of this presentation. I kind of came in with Heidi and Stephanie towards the latter part of their extensive stakeholder engagement and collaborative effort, and I was part of the educational sessions that have gone on for education about this initiative. And the thing that struck me and the feedback that we heard from the care providers, both pharmacists and physicians who we've presented it to, is that one of the wonderful things about this initiative is the real-time access to all the medications. So any provider can go online and see the medications that were dispensed, whether they're opioids or non-opioids or cardiac meds at any time. And we all know that the prescription and treatment with opioids is just part of that patient. And there's often a lot of other things that are going on. So this is the ability to actually see the whole patient with many of the other aspects of their that are important in their care, including lab work, investigations, hospital admissions, emerge visits, and as Heidi said, more to come. So this has primarily been an educational intervention for providers to see how they can use what's available so that they can try and change or improve their prescribing with opioids. And importantly, to realize that every one of us, I think, has an important role to play in this area. The attendance was amazing. We tapped in this collaborative environment, we tapped into the community hospital programs that are available in our communities through the New Brunswick Medical Society to have some of these sessions. Extremely well attended. So they learned about the eHealth New Brunswick and the monitoring system that was added. They learned a little bit about more about opioid prescribing and the role to play. And it created quite a discussion and feedback session for us in terms of the important things that they found as providers that they needed. So the feedback we heard from them in summary was that they really appreciated all the information that was being provided to them and that the physicians want to be part of the solution. Sometimes, particularly with opioids, it doesn't really fit in one particular place. You know, when you're talking about stroke, well, that's neurology. When you're talking about a heart attack, well, that's cardiology. When you're talking about opioids, it doesn't really fit well into any of our silos that we've created. And it actually crosses all of those silos. So actually trying to find the right environment for all of us to come together to talk and to share our experiences makes a difference. It was very clear that there was the physicians and felt that there was a lack of community resources for some. They want to try and help these patients come off these medications, but how do we do that? It's not just about lowering the prescription dose and tapering them down. How do you plug them in? Even with the methadone programs and the things that we have, how do we help? More opportunities to work together to learn better ways to help patients with pain management and their opioid prescriptions. And the feeling we got from all of this is that we were on the right track. We're all moving down the road together to try and figure out how do we make a difference in the system. Where to from here? I think if you also think back to how do prescriptions get generated. Prescriptions get generated by physicians, and I'm going to put my physician hat on here now, in the spirit of trying to be helpful to the patient. And so if the information's coming to the physician is about pain or it's about anxiety, what the physicians are trying to do is be responsive to that. And we also respond to the other providers who are around us. So the nurses we work with, the pharmacists we work with, when they're coming to us and saying, you know, the pain seems to be worse or the anxiety seems to be worse, so we're trying to respond. So to me, it makes perfect sense in a collaborative effort like this that things like choosing wisely to manage patient expectations about really what we can really do to control pain, and as well as managing and educating expectations of our allied health professionals. Because there isn't a night on call that I don't get a call about, can I have a sleeping medication? Can I have an increase in a narcotic? Can I have an increase in an anxiolytic? On and on it goes. So how do we all together manage the expectations? And lastly, I'm just going to say in New Brunswick, we're very thrilled as part of the eHealth New Brunswick initiative to be putting into place in early May eConsult, which is going to be patient-specific questions from family physicians to specialists in a pilot phase to look at some of these areas to increase access to specialists, but chronic pain will be one of those areas that we'll be targeting. So we're just starting at seven specialties, but we are hoping that all of this stuff will be integrated, and the eHealth New Brunswick has made a big difference to help us do that. So thank you.
Thank you very much to the three from New Brunswick. Our next speaker, just to keep you on a random order again compared to the program, is a second-year medical student at Queen's University. His name is Sachin Pasricha. How'd I do? Okay, good. And he has a keen interest in drug policy. He's actually worked with us one summer at the Canadian Agency for Drugs and Technologies in Health, and he's also worked with the Ontario Drug Policy Research Network, which I think is where his current presentation is coming from. So welcome, Sachin.
Slide this forward. Oh, right here, perfect. So my name's Sachin. I'm a medical student, as you heard, from Queen's University. I'd like to thank you all for having me here, and as mentioned, the work I'll be presenting today is work I did with Ontario's Drug Policy Research Network last summer under the supervision of Dr. Tara Gomes. And to begin with, I'd like to point out my disclosures. I did receive summer studentship funding from the ODPRN, and as well, I'd like to thank CADTH because of their Student Travel Award, which allowed me to come here. So we talk a lot about opioids, and we've talked a lot about them today. And a lot of the times we focus on the potentially negative consequences of these opioids, whether those be opioid-related deaths, side effects, or road trauma. And to me, these are really branches on the tree of opioids. And what I mean by branches is that we're treating all these individuals who are using opioids as if they come from one common place. And that commonly discussed place is, well, pain management. But the reality is there are a lot of different pains for which people initially start on opioids. And we've heard a little bit about this in some of the other presentations. For example, people use opioids for back pain, and potentially, maybe, these people who start on opioids for back pain are more likely to develop addiction. We heard about migraines in a previous presentation. People also might use opioids after surgery, and maybe those people are more likely to experience opioid-related side effects. These are important questions, but before we begin diving too much into these questions, we have to ask the first question, which is what are those actual pains that people are starting on opioids for? And that's a very important question. And what that's really asking is what are the clinical indications for which people initiate opioids for pain management? And that's what we wanted to do, and that's the work that I was working on last summer. So some other literature has looked at this idea of the clinical indications for initiating opioids, but they've done it in relatively niche contexts, whether that's musculoskeletal pain or primary care. And as you can imagine, if you're just looking at the primary care population, you're probably going to underestimate the amount of people that start on opioids after surgery. Makes sense. So really what I'm getting at is that we were missing at a population level this idea of looking at the clinical indications for initiating opioids for pain management. So that is what we wanted to do. And I've talked to you a little bit about the gap in the literature, but more specifically, why do we care about this? Well, one of the reasons, as you can imagine, is we want to know, are these indications appropriate? Are these initiations appropriate also in terms of dose, duration, etc.? There's also a push for pain management alternatives, whether those be chiropractors, CBT, physio. But if we're going to develop alternatives for pain management, it probably makes sense to know what the pains are. As well, there's this push which is gaining some momentum to, instead of having guidelines for pain management by drug class, so guidelines for opioids as a whole, to focus and prioritize more on creating guidelines by clinical indication, so by the specific pains. But if we're going to do that, we also need to know what are the pains. And finally, very important probably to a lot of the people in this room, is the resource allocation of healthcare dollars and the resource allocation of efforts to promote safe prescribing. And that resource allocation could very well benefit from this work. So I've told you what we were doing. How did we do it? We had a variety of data sources, all of which came from ICIS, the Institute for Clinical and Evaluative Sciences, and they have administrative healthcare data. I won't tell you about all the data sets, but I will tell you about one, which is the narcotics monitoring system. And the reason I tell you about that is because the prescription monitoring systems you just heard about, the prescription monitoring programs, that's Ontario's version of it. And so this data set is actually what allowed us to look at the entire population for the first time and say, what are the clinical indications across that entire population? So we went to that narcotics monitoring system and said over a 1-year period, April 2015 to March 2016, we looked at people who were dispensed an opioid. And then we had some inclusion and exclusion criteria, the most important of which were we didn't include people who were previously dispensed an opioid. We really wanted those who were new initiators, new users. And we also excluded those whose opioid was prescribed as a part of OMT, opioid maintenance therapy, or for cough. And so really, we ended up with people who were new users of opioids for pain management. And then it was our job to identify what pain did they have, what clinical indication. And we did that using all that other data and a long stepwise hierarchical approach. It's long, it's complicated, but it can really be summarized in 3 steps, 3 simple steps. The first said, okay, if their prescription came from a dentist, they had dental pain. If they had evidence of cancer in the past 12 months, they had cancer. If they had evidence of palliative care in the last 12 months, they had palliative care. That was step 1. Then we went to the date that they were dispensed their opioid, and we looked back 5 days. And we said, okay, in those 5 days prior, did they have any procedures? Because if they had given birth or had a surgery, well, that was the reason most likely that they had been dispensed opioids. And similarly, in those 5 days prior, we said, did they interact with any healthcare professionals? Because if they did and they received a diagnosis of gallstones or back pain, well, that was the indication. And after all that, we still had a group of people for whom we didn't know what pain they had, an unknown group. So in summary, we had those new users of opioids, and we used an approach to classifying, well, their clinical indications. And we ended up with 23, which was a lot, so we grouped those into 6 indication clusters. And really quickly, why I highlight that there were indication clusters and indications is because we went and grabbed prescription and patient characteristics. And some of those we grabbed for both the indications and the clusters, such as daily dose, duration, and the relative contribution. But others we just looked at by indication cluster. Okay, so now what did we find? Well, in that 1-year time period, 650,000 Ontarians newly initiated opioids for pain management. 650,000. But how did that look across all those indication clusters? Well, sitting there at the top, dental pain was the most common pain cluster for which people initiated opioids. And to provide you some more context, these are the more specific indications that made up each cluster. So as you can see, within dental pain, the majority of that was from dentist prescriptions, the rest being from physician prescriptions. Other indication clusters included post-surgical, musculoskeletal pains, trauma-related pains, cancer and palliative pains. And then there was this group of other pains, which the most common of which was abdominal pelvic pain. There were also kidney and gallstones. And I also highlight a few other indications there, headaches and migraines and infection, migraines we just heard about. And the reason I highlight those without going into too much depth is because people are still being dispensed opioids for these indications, and the evidence that the benefits outweigh the risk is perhaps questionable. I won't go more into that, as we already heard about that in a previous presentation. But in summary, this is the relative contribution of each clinical indication for people initiating opioids for pain. And then, like I told you, we looked at the daily dose. And the numbers for our overall cohort are there at the top, with a median of 34 milligrams of morphine equivalent. We also looked at what proportion of people were starting on daily doses above 50 milligrams of morphine equivalent. Why we cared about that was, well, guidelines recommend starting at lower daily doses, and the reason is because higher daily doses are associated with more side effects. Okay, so if you look at the numbers by cluster, most of them seem to reflect the overall numbers, except this post-surgical group. Okay, and then when you go and you split it up by the actual surgeries, there are two key surgeries that stand out. Knee, hip, and shoulder surgeries. The 75th percentile there is 90, which means that a quarter of people who were initiating opioids for knee, hip, and shoulder surgeries received a daily dose at initiation of 90 milligrams of morphine equivalent or higher, and 65% received a daily dose at initiation of greater than or equal to 50. And the C-sections, people who initiated for those were also receiving relatively high daily doses. As well, outside of the surgical cluster, kidneys and gallstones were a group that people in that who were initiating opioids for that also had higher daily doses. Now, we also looked at duration similarly. Instead of looking at greater than 50 milligrams, greater than or equal to 50 milligrams of morphine equivalent, we focused on greater than 7 days. Why? Well, because longer doses longer durations, at initiation may be associated with more risk of long-term use. So again, if you go look down the indication clusters, most are reflective of the overall numbers, except for this musculoskeletal pain group. And of note, there's a median of 5 days, but as we all know, that doesn't mean that everyone in that musculoskeletal group is receiving 5 days opioid supply at initiation. In fact, a quarter of them were receiving an initial prescription with a duration of 10 days or more. And then when you look at the actual clinical indications, that's reflected in both joint and muscle and back pain. And another clinical indication which had seemingly longer initial prescriptions were headaches and migraines. Okay, and so of those 650,000 people, what formulations were they prescribed at initiation? The overwhelming majority were prescribed only immediate release formulations. And when you look at patient characteristics, I'll just highlight the median age, which was 48, with the cancer and palliative group being slightly older, okay, and the dental pain group being slightly younger, okay. So this is where we started, by looking at the clinical indications for which people are starting on opioids for pain management. And I presented you with a lot of different results, and you're probably wondering, what do I take from this? What are the main messages? And so I will highlight 3 for you. Because as you can tell, there's a wide variety of reasons and pains for which people initiate opioids. So for the first of my takeaways is this. We looked at relative contribution, and what we found is that dentist prescriptions account for over a fifth of opioid initiations. Over a fifth. And that youth tended to be more common in that group, and why we care about that is because youth are a group that's at increased risk for opioid-related overdoses and opioid-related hospitalizations. Then we had that post-surgical pain group, which were prescribed higher daily doses at initiation, but short durations. And sort of in the converse to that, we had the musculoskeletal pain group, which were prescribed longer durations at initiation, but lower daily doses. And I've also told you a little bit about why we care about those things. So the 3 takeaways are as follows. The contribution of dental pain, the higher daily doses in those who are initiating opioids for post-surgical pain, and the longer durations at initiation of those who are initiating for musculoskeletal pain. And these three takeaways really nicely set up areas and avenues for future research. For example, we could look at those dentist prescriptions and ask, are there risks of long-term use? We could ask in that post-surgical group, are people ever getting refills on those initial prescriptions? As well, the musculoskeletal pain group, which had longer durations at initiation, is this intended or unintended? As well, this research, like any, has to be taken in the context of its limitations. The first of which is that we had that stepwise hierarchy, that picture that I showed you, that was aimed at classifying the clinical indication for which people initiated opioids. While we couldn't ascertain for sure 100% if we identified the correct clinical indication for initiating opioids. As well, we had an unknown group. And all previous, those niche studies that I talked to you about that have tried to do this, they had larger unknown groups, but ours was still 78,000 people, worth noting. And finally, we gave everyone one single pain indication for initiating opioids. But in reality, pain is multifaceted, and they may have had multiple pain indications. So I told you what we did, and I'll just highlight for you again why we did it. We wanted to know, are these people who are initiating opioids, are these initiations appropriate? And we also wanted to inform the prioritization for policymakers and clinicians. The prioritization in terms of pain management alternatives, guidelines by clinical indication, and resource allocation. I'd like to highlight for you that if you do want to know more about this research and look more in depth at the numbers that we found, we do have a manuscript coming out in pain in a couple of weeks. It should be up. But for now, I'd like to thank you all for listening and hand it over to the next speaker. Thanks.
Thanks so much, Sachin. So we have one final speaker today. That's Nick Bansbach. He's an associate professor at the School of Population and Public Health at the UBC and co-lead of the Health Economics and Simulation Modeling Methods Cluster at the BC Support Unit. And he's going to talk today about cost effectiveness of hydromorphone for long-term opioid dependence.
Thank you. So slightly different topic. This study is going to be considering the overdoses and deaths that are happening every day due to opioids. And this research is really, I should acknowledge all my co-authors here at the Centre for Health Evaluation and Outcome Science who have been doing this research for a number of years. The study was primarily funded through CHR, of which I was a co-investigator, but there's been a number of other funders to this work. So the background to this is that substitution treatment with treatments like methadone are very effective, and they prevent individuals from using street drugs. But there's a subpopulation of users who we define it as have severe opioid use disorder, who are not attracted or maintained to these treatments. And so this subpopulation are particularly at risk of overdose because they're using street drugs, which we know has a high frequency of fentanyl and other analogues. But just to note, this is not the only population that is having overdoses due to the opioid crisis. So back in 2009, the Naomi study was published by my colleagues at CADTH, and this study compared injectable diacetylmorphine, which I'll call DAM from now on, compared to methadone, given with supervised care. And this study had quite dramatic findings, showed that patients were retained in treatment for much longer and had much less street drug use during their treatment with DAM. And it's not surprising, this is one of 8 RCTs that have shown similar findings, but it's the only RCT that's been done in North America so far. but Health Canada didn't approve DAM for routine use. So the investigators then chose to study injectable hydromorphone because it has a similar pharmacology to DAM. And whilst it's not currently licensed for opioid maintenance, it is licensed for moderate to severe pain, and so it's much sort of easier from a regulatory and political standpoint to be prescribing hydromorphone. So the study, Salome study, which was published at the end of 2016, was a non-inferiority study comparing hydromorphone to DAM. And the findings were effectively that there was non-inferiority between those two treatments in terms of days of heroin use, any other street-acquired opioids, and positive street heroin markers. So the objective of this study was to first consider the 6-month cost-effectiveness of hydromorphone versus DAM, and that's a within-trial analysis of the Salome trial. But then secondly, to consider the long-term cost-effectiveness of hydromorphone versus DAM and methadone. So that was using a decision analytic model which extrapolated data from both the Salome and Naomi and other data over the lifetime of patients. So the methods for the within-trial analysis, this used the patient-level data from the 202 individuals in the Salome trial. We considered costs which included the actual treatments itself, the provision, the supervised environment and treatment facilities that these treatments were given. Then there's other costs related to HIV treatment, inpatient, outpatient care, property and violent crime, which was self-reported, and then criminal charges, which we obtained from Vancouver Police Department. We considered QALYs using EQ5D, and other methods are below. For the lifetime analysis model, we adapted a previous model that our group published in 2012. This model considers health states of treatment, relapse, abstinence, and death. And so the costs and transitions are dependent on the health state that people are in. These transitions, costs, and utilities were, where appropriate, derived from the Salome and Naomi studies. So how this worked was we had the Naomi study, which considered DAM versus methadone. We have the Salome study that considered hydromorphone versus DAM. And so by combining them with the patient-level data, we were able to make an indirect comparison between hydromorphone and methadone. We also did a sensitivity analysis which considered a more formal network meta-analysis of other trials which have considered DAM versus methadone, but only at the aggregate level. So lots of numbers. Let me just tell you the bottom line for the within-trial analysis. We effectively see effectively equivalent QALYs between hydromorphone and DAM. The costs of hydromorphone were slightly higher, but this was all down to the involvement in property and violent crime, which was higher in the hydromorphone arm. But actually, when you dig into that data, it was related to 4 or 5 individuals. And so the confidence intervals around those are very large. So if you plot this on as a scatter plot, it's a big blob around the origin, and effectively it's saying that there's no real difference in the cost effectiveness between these two treatments. The lifetime analysis estimated that individuals on the hydromorphone arm would be living for, on average, about 18 years, which compared to about 15 years on the methadone arm. So about 3 additional life years on average by providing injectable hydromorphone. Similar, DAM was quite similar to that as well. When you work that out in terms of QALYs and discounting, it's around 1 additional QALY by providing either hydromorphone or DAM versus methadone. In terms of the costs, the methadone arm was the most expensive, and so both DAM and hydromorphone would save about $140,000 in costs. Now, of course, the actual upfront cost of both DAM and hydromorphone is more. The savings are coming predominantly through the reductions in property and violent crime. So, for example, we were able to work back and estimate that the patients who were given either hydromorphone or DAM were estimated to reduce have 6 less property crimes attributable to themselves than if they were on the methadone arm. So these strategies provide more QALYs at less cost. They are what we call the dominating strategy. And so both hydromorphone and DAM had very high probabilities of being cost saving and providing more benefit. And if you compare the two, hydromorphone versus DAM, there's a mistake in that far right slide. It should say hydromorphone versus DAM. On the far right there, it shows that they're effectively equivalent as well. We've done a number of scenario analyses. Again, enough numbers. What I'll tell you is that that answer doesn't really change, except for 2 of the scenarios. The first scenario is if you choose to ignore the crime costs, then that does change. And the second scenario is when you consider different pricing for hydromorphone. That's where it does also change. So the finding is that hydromorphone could be a very attractive use of healthcare resources from a taxpayer societal perspective. If you consider the criminal costs into your calculations, but of course, and as with any conversation about drug costs, it is dependent on the negotiated price of hydromorphone. This is a generic treatment, but still it is worth to note that the doses that were used in our study were much higher than the doses that it is used for pain management. And so there are some issues around the pricing of hydromorphone that are important to consider. Also, it's important to consider that DAM is also very cost effective as well. But the reason for the interest in hydromorphone is more that it's just DAM is more pragmatically, it's more complicated to deliver. And so hence injectable hydromorphone is slightly easier to be working with. There are some limitations. So we focused just on property and violent crime. There's a whole number of other really important issues and costs that we would really have liked to have considered, and they would have only changed the costs in one direction of making it even more cost saving. And so we would really want to do more in future to be trying to estimate some of these costs. They are just, as you can imagine, quite challenging to measure. We, of course, used a number of extrapolations and assumptions around the transitions, some of which actually are changing, particularly sort of the mortality rates in the states of relapse are changing quite dramatically. And so whilst we cover them in different scenario analyses, they are quite hard to know what the accurate numbers are. We probably oversimplified our health state around relapse. Just saying it's one health state doesn't cover what relapse really is. And so we've sort of played around with that to see whether it would make an impact. It wouldn't change the conclusions, but we could probably look into making that more comprehensive in the future. And then, of course, we've compared hydromorphone to methadone indirectly, which means it's more susceptible to bias. But the conclusion is that injectable hydromorphone with supervised care would save lives and taxpayers' money. And If you're interested more, this publication came out 3 weeks ago, where all these results are included, along with an appendix with all the assumptions. And I must acknowledge, particularly from the Salome and Naomi trials, the trial participants, the frontline workers at the Crosstown Clinic, the research team, and the many partners to this work. Thank you very much.
So thank you very much to all of our speakers today for some really interesting presentations. I wanted to remind people online that you can submit questions to events@cadth.ca if you'd like to ask a question of the panelists. And I'd like to invite anyone in the room that if you have a question, I may need to repeat it into the mic unless you want to pop up and speak it right into the mic. I'll give you the choice. Go ahead.
Hi, Sean Mugden from Memorial University. A couple of questions. Nick, I couldn't see the sensitivity analysis on the hydromorphone price. What did it say?
So the question is the sensitivity analysis on the hydromorphone pricing for Nick. You'd have to hold.
So it says that if you use the list price, then actually it's quite expensive. But for various reasons, and it's hard to talk too much about it, there's pretty good reason why we're going to get pretty good negotiated price, and so using the list price just isn't it's a little silly, which is why we have shown it, but it's not particularly relevant. It comes down to the fact that the doses that we're using are so much higher, so that's where the complexity comes. We almost need a different indication, a different formulation of injectable hydromorphone for this group, which is priced differently, and that's kind of what we need. Like similarly to what happens for other pharmaceuticals, which are used in different conditions, like Lucentis and things like that.
Yeah, but in theory, there would be a lot less barriers in the way of moving forward with that from a regulatory perspective.
Yeah, like there's lots of conversations going on right now about that pricing.
And heroin is a bad word, I guess.
Yeah, we use DAM.
Yeah. And just one follow-up for Sebastian. It really well presented, excellent stuff. I'm looking forward to the paper coming up. We've just done an analysis in Manitoba on the dental prescribing, and our conclusion was, although there are frequent people that are initiating opioids, they almost always have small quantities. They very rarely have refills. So our overall conclusion was that dentists really don't seem to be a big part of the overall problem. Yeah, I don't know what your thoughts are.
Sasha, can you just repeat that? Paraphrase.
Sure, yeah. So essentially the question or comment was related to how they did an analysis in Manitoba.
Yeah.
And in Manitoba, and what they found was that dentist prescriptions, even though they're an important contributor, they're relatively short duration and lower daily doses, thus they're not an overall contributor to long-term opioid use. And even though I didn't highlight it in our discussion, if you recall from the earlier slides, we found the exact same thing. Dental prescriptions, big contributor, but low daily doses, low duration. So are there a subset of these people that may go on to develop long-term use? That's probably a good question to ask still, but we found similar stuff.
Yeah, and I think what we found is it's vanishingly rare with dentists. So I think we can make a job.
Are there other questions in the room? Yeah.
The way I think about pain is I divide into categories of acute, chronic, and endemic. And then
The question is about, sorry, can you?
Yeah, I'm sorry to say, but as the economist involved in this, I'm probably not best to answer that question, but my colleagues would be more than happy.
An excellent response.
Yes, at the back.
So the question is for Nick on where Suboxone or buprenorphine naloxone fits into their cost effectiveness study.
Yeah, right now it's not in there because at the time that the Naomi and Salome trials were being conducted, it wasn't being largely used. And so what we're doing now is trying to indirectly add that into the model. But I think equivalently, the point would still remain is that once you have sort of failed or people are still not attracted to those sort of first lines of second line treatments, then that's the subpopulation for which injectable hydromorphone would become sort of the option. So I think they're not looking to move too quickly to that, and so wanting to use all of the effective treatments before that when needed.